Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On the podcast today, I'm joined by our deputy editor Nick Bostock to talk about some of the key news affecting general practice. Coming up, we're talking about advice and guidance. Practices will be paid for advice and guidance under a new directed enhanced service that started as part of this year's GP contract. However, there's huge variation of uptake of advice and guidance across England, so we'll be looking at that in more detail. We're also talking about public sector pay reviews and whether the government is likely to agree to fund recommendations for this year if they are over and above the 2.8% that has been planned for. And we'll be looking at the state of GP premises and discussing the chances of additional funding in the coming year. Our good news story is an update on a story we discussed a couple of weeks ago about enhanced services in Lancashire and Cumbria. So first off, let's start with advice and guidance. So for people who don't know, advice and guidance is a system where GPs can submit queries about their patients to hospitals and get advice about possible management options or whether or not patients need to be referred. Nick, these systems have been controversial in recent years for GPs in lots of parts of England because many doctors believe advice and guidance can lead to GPs being left with lots of work that they're not being paid to do and work that would have previously been carried out in hospitals because patients would have been referred into the hospitals. But from this year, practices will now be paid for this work, won't they? I mean, we've talked about this on the podcast before, but maybe briefly explain this new advice and guidance enhanced service for us.
Advice and guidance, like you said, is basically a system that's meant to give GPs access to advice from hospital specialists about how to manage patients. It's something that's been in place for several years, and until now, GPs have mostly not been paid for it at all, despite the fact that it can mean practices taking on responsibility for tests or bits of care that would otherwise have been carried out in a hospital. I say GPs have mostly not been paid for this because in some areas they have been. Some ICBs have made the decision off their own bat, individually, that paying GPs to engage with advice and guidance is something worth paying for, and the government now seems to have come to the same conclusion. So the Advice and Guidance Directed Enhanced Service, which kicked in from April, offers GP practices £20 per request submitted through advice and guidance. And the government's hope is that this can reduce referrals to hospital and help to bring down the NHS waiting list. NHS data suggests that advice and guidance prevented around 660,000 hospital referrals by GPs in the second half of 2024. So it's something like 1.3 million a year. And the government's hope is that paying GPs for advice and guidance can drive that up to about 2 million referrals stopped a year.
Yeah, so this new enhanced service is really part of the government's push to reform elective care, cut the waiting list, and to a certain extent transfer some funding from hospitals to the community, albeit that on a very small scale. The £80 million funding for the enhanced service has effectively come from hospitals' elective care budgets, and each integrated care board will get a share of that funding. How's that going to work?
The £80 million total funding pot is shared out in the same way as the basic funding ICBs receive. So it's based on a formula that looks at how many patients they have, as well as morbidity, deprivation, and the costs linked to providing services in each area. So it factors in things like rurality that might add to costs. There are 42 integrated care boards, ICBs, in England. And there are really big variations in the size of the population they cover. So although the average share of the advice and guidance pot per ICB is something like £1.9 million, the range of budget ICBs will actually receive goes from just under £700,000 at one end of the scale to more than £4 million at the other end. And because they're operating within a fixed pot of funding, ICBs have been told that they can set caps on the total number of requests practices in their patch can make. That could be a monthly, quarterly or annual cap potentially. But to translate this into something that might mean a bit more at the level of an individual GP practice, that overall 80 million funding pot suggests that an average size practice with about 10,000 patients should be able to make about 650 advice and guidance requests a year at £20 per request. So that's something like 50 to 55 a month. And it could earn a practice of that size around £13,000 a year.
You've been looking at current levels of uptake of advice and guidance, and it's a really mixed picture across England, isn't it? What did you find?
The NHS publishes data on requests for specialist advice, and those figures are used as a measure of advice and guidance. When the government first mentioned plans for an advice and guidance DES, Directed Enhanced Service, which was back in January, it talked about driving up the total number of requests GPs send through the system from about 2.4 million a year to about 4 million. So that's requests as opposed to referrals prevented, which was the figure we were talking about earlier. The most recent figures available for March 2024 to February 2025 suggest there are about 2.5 million requests for specialist advice in that 12-month period. So that suggests advice and guidance doesn't seem to have slowed down, despite the fact that GPs were advised to consider refusing to engage with advice and guidance as part of collective action in the second half of last year. But there is really big variation between areas. So some ICB areas processed nearly 350,000 requests for specialist advice over the past year, while others did less than 30,000. So that's more than tenfold variation, and that isn't explained by variation in the population between ICBs. And what that means is that while in some ICB areas, GP practices are already making enough requests through advice and guidance to consume all of their ICB share of the national £80 million budget, or in fact, well over that amount in some cases, in other areas, practices would have to triple the number of requests they're making to claim the full funding available. There's another part of these figures, which is probably the bit the government's most interested in, and that's the bit that estimates how many hospital referrals have been avoided or diverted as a result of these requests for specialist advice. And like I said before, the second half of 2024, around 660,000 referrals were avoided by advice and guidance. So it's roughly 1.3 million a year, and the government wants to get that up to 2 million. So that's the bit the government's most interested in, because referrals that don't happen don't add to the NHS hospital waiting list, and bringing that down is probably the number one concern for ministers.
Basically, it means that there's GPs in some parts of England that will effectively now earn money for work that they're already doing, and they won't need to do anything differently to earn the maximum amount that's available. And then there's GPs in other parts of the country that will have to do more to get the money that's on offer. I went to an NHS England webinar quite a while ago now when the contract was first announced, and NHS England was suggesting that ICBs may spend over and above their allowance on advice and guidance for GPs if they felt it was helping them with their elective targets. But it's not a guarantee, is it, that there'll be more money available, particularly now ICBs have a lot more to worry about in terms of these massive cuts they're facing. The government has said that this money is going to pay to really expand the use of advice and guidance, but there are some big question marks about how these caps might actually end up working in practice, aren't there? I mean, what have GPs been saying to you about all of this? How do they think this advice and guidance enhanced service is going to work out in reality?
The GPs I've spoken to generally say that overall it's a good thing that practices are now being paid for advice and guidance, which they've previously been under pressure to do for free. But there are still some real concerns. I mentioned earlier that mostly practices haven't been paid for advice and guidance up to now, but in some areas they have been. And in some of the areas that paid GPs to engage with advice and guidance, they paid more than the £20 per request that the new national scheme is offering. So it's obviously, like you said, it's quite possible that some areas that were already paying for it, if they were paying more, they could use some of that money to pay for an amount of advice and guidance over and above the basic allocation they've got. But in the new situation of the cuts they're being asked to make, that's absolutely not guaranteed. And there are some real concerns. There's a worry that the money on offer isn't enough. We've discussed that before. There's a concern that because the funding available is capped, if you're not in an area where there's any history of being paid for advice and guidance, what happens when the money runs out, when your practice has hit its limit for the month or the year? GPs are worried that basically they'll be under pressure to keep using advice and guidance, but without being paid for it. So that could mean that £20 per request turns into £15 per request, or even less ultimately. One of the GPs I spoke to said that GPs should ultimately be guided by doing what's right for the patient in front of them. If they feel advice and guidance is going to help in the case of the patient who's sitting in front of them, then fair enough, use it. But whatever, he said, don't feel pressured into doing advice and guidance. There was some scepticism too about whether advice and guidance will really reduce referrals in the way the government hopes. But one GP I spoke to said that practices aren't referring patients to hospital for no reason as things stand, and that advice and guidance ultimately isn't going to change the fact that if a GP thinks a patient needs to go to hospital, then probably they do.
Yeah, definitely. The BMA has also said that it is going to be putting out guidance for practices on all of this. So we'll need to wait and see what that has to say in the coming weeks as well. Before we move on, just to let you know that MIMS Learning Live is returning to London on Friday the 13th of June, and this year it's heading to a brand new venue, the ILEC Conference Centre in Earls Court. Brought to you by our colleagues on MIMS Learning, this is an event you won't want to miss. It's your chance to boost your clinical know-how, connect with peers from across the UK and gain fresh insights that can help make a real difference in your patients' lives. Spots will go fast, so head to mimslearninglive.com/London and get your ticket today. So Nick, let's talk about pay increases. The GP contract deal for 2025-26, which we've talked about a lot on this podcast, has basically built in an assumption that practices will give staff a 2.8% pay increase and that partners should also get a 2.8% pay increase from the deal. But there's always been a recognition that this could rise further potentially when the Doctors and Dentists Pay Review Body, or the DDRB, makes its annual recommendations, hasn't there? Just briefly explain how the DDRB process works if people don't know.
The DDRB is one of a raft of independent advisory groups that make recommendations to the government on pay for different parts of the public sector. There's a review body for teachers, for doctors and dentists, the DDRB, like you mentioned. There's one for the wider NHS and so on. And each year, as part of the process of determining pay increases for doctors, the government and organisations like the BMA, NHS England and others submit evidence to try and influence the recommendations that come out from the DDRB. For GPs, there's a parallel process in which the government, NHS England and the BMA negotiate over changes to the GP contract for the next financial year. And then the DDRB advice is often sort of retrofitted onto that. And mainly that's because its advice tends to come after the start of each financial year. Although that's something the government is committed to trying to fix from April 2026, I think. The government then decides whether it's going to implement the advice from the DDRB. It's not obliged to, but ignoring DDRB advice would probably risk an industrial dispute and possibly a return to something like the NHS strikes that we saw a year or so ago.
Also, probably worth pointing out that the DDRB report is also relevant to listeners in Scotland, Wales and Northern Ireland, because governments there also receive these recommendations and they decide independently from the government in Westminster about whether or not they uplift pay in line with those recommendations. And we have seen in previous years governments in different countries going very different ways on pay and how they respond to those recommendations. So we're expecting this year's DDRB report imminently, aren't we? Do we know anything about what it's likely to say?
We got the first hints this week of what the uplift for the NHS could be, although, to be clear, we haven't heard anything specific about general practice. As you mentioned, the pay rise built into the GP contract deal for 25-26 was 2.8%. That's the pay rise the government expects the deal as it stands to deliver for GPs and practice staff. But the Times reported this week that the uplift for NHS staff could be something just over 3%. So it's higher than the government assumption, but at the same time, it's nothing close to what the BMA would like to see. So we could see an announcement fairly soon on what the DDRB advice is and what the government has decided to do with it. And the question is, how far will whatever comes out of that go to satisfying GPs, other doctors and NHS staff? Will it maintain the improved relationship between NHS staff and the government that we've seen since the general election, or perhaps reopen old wounds and lead back to more of these industrial disputes?
If people haven't listened to last week's interview, which was with the BMA's GP Committee Chair for England, Dr. Katie Bramall-Stainer, I asked her about the DDRB recommendations, and she said she hoped it would recommend something over and above the 2.8%. I mean, obviously she would say that, but what was interesting is that she said the review body was really interested this year in hearing the BMA evidence, and that the BMA presentation of that evidence went on for longer than normal than it has done in previous years. And the review body was particularly interested in what the BMA had to say about what was motivating GPs to leave the UK and what happens when practices close and when they're forced to merge and what the impact on patients is. So she was actually hopeful that the DDRB would take all of that on board and recommend a higher pay increase. But Nick, when the final report does come out, what is the government likely to do with that information, do you think? If there is a recommendation on a pay increase that is over and above that 2.8%, how likely do you think it is that the practices will get that extra funding on top of this year's deal?
As I said, the government isn't obliged to implement what the DDRB recommends, but it would definitely think long and hard before undercutting DDRB advice because of the impact that would inevitably have on its relationship with NHS staff. If the recommended uplift is above the 2.8% original assumption, but fairly close, as this Times report suggests, it seems pretty likely the government would find the money somehow to pay for that, to try to avoid a dispute. Stephen Kinnock, the primary care minister, didn't make any promises. He said on Sky News that the government was all about putting more money into workers' pockets and that the government would give careful consideration to review body advice. But he also said the government had to work within tight fiscal constraints, and he said that unions would have to be realistic. My guess ultimately would be that we'll probably see the government award what the DDRB recommends, but that the DDRB recommendation will fall short of satisfying what the BMA and other unions really want to see.
I think that's probably quite likely. I mean, Stephen Kinnock was very keen to point out the fact that the government had brought an end to the dispute with junior doctors, or residence doctors, as we now call them. But resident doctors in England and, in fact, in other parts of the country have not stopped their campaign for pay restoration, even though they're no longer in dispute with the government. They will be expecting to see some measures in this year's pay deal that go towards addressing that, won't they? And it's not just the resident doctors, all of the hospital doctors groups at the BMA, so the resident doctors, consultants and SAS doctors sort of fired a shot across the bows on this really at the start of April. They wrote to the government and warned that any delays to the pay review process for this year risked reopening disputes with the government, as you've mentioned. And they're basically very unhappy that yet again decisions on pay for this financial year have not been made early enough to actually come into effect at the start of the year. They want the government to publish the DDRB report without delay, and they're also saying they expect the government to re-enter negotiations with the BMA if the recommendations do not show sufficient progress towards restoring doctors' pay. So even, like you say, if the government does implement those recommendations in full, if the resident doctors in particular don't feel that this has gone far enough on pay restoration, the government could still find itself potentially facing some sort of dispute and threats of industrial action. One other thing that's probably worth mentioning here is what's happening in Scotland, which is very much tied to funding. Regular podcast listeners may also remember a recent conversation I had with the chair of Scotland's BMA GP committee, Dr. Ian Morrison, where we were talking about the likelihood of industrial action by GPs north of the border. There's been some developments on that this week as well, hasn't there, Nick, with the BMA really stepping up its campaign to pressure the government to increase GP funding there.
Although in England at the moment things are relatively calm on the industrial action front, despite potential tension around whatever the DDRB ultimately recommends. In Scotland, GPs are really stepping up pressure on the government over funding. BMA Scotland's GP committee has recently launched a campaign to try to build patient support for more funding for general practice. And they're warning that as things stand, by failing to tackle underfunding, the government is driving GPs towards an industrial dispute. BMA Scotland says inflation has far outpaced funding increases over the past decade and a half, and that practices need an extra £290 million to reverse that funding erosion. It says the government has promised more GPs, but that full-time equivalent GP numbers have dropped over recent years, and that the future of general practice, as things stand, is at risk. We reported a while back on the fact that the GP unemployment crisis, which initially seemed to be an England issue, had now emerged in Scotland as well. And that suggests that, as in England, there are issues with practice simply being unable to afford available GPs. We know from BMA polling that most GPs are prepared to take part in industrial action in Scotland. So the ball's now in the government's court. It says it's increased investment in general practice and that it's still pushing to boost the workforce in line with what it's promised. But as things stand, that hasn't been enough to meet what GPs want to see. And this possibility of industrial action is very real.
So let's talk about GP premises. Nick, we're talking about this because the NHS Confederation called on the government this week to ensure there was a significant boost to capital spending on primary care premises in the forthcoming spending review. What did they actually say, and why is it significant that they're saying it?
In last October's budget, the government announced a £3.1 billion uplift to NHS capital funding and a £102 million fund for upgrading GP premises. But basically, the NHS Confederation is saying that's all welcome, but it's nothing like enough. And specifically, that primary care premises really need investment if general practice and other community services are going to take on more work from hospitals, as the government wants to see. I think what's really significant about this is that this isn't just the BMA or the BMA GP committee calling for more investment in GP premises. It's not just GPs asking for more money. It's an organisation representing NHS leaders saying this investment is essential. So this is effectively recognition from senior figures in the NHS that the government needs to invest in GP premises now or risk its whole NHS reform plan ultimately falling apart.
Your story highlighted some of the real problems with GP premises. I mean, we have talked about GP premises on the podcast before, and anybody who actually works in general practice will know about some of the challenges facing premises. But your story mentioned Lord Darcy's review of the NHS, which he conducted shortly after the Labour government came to power. And in that report, Lord Darcy said the primary care estate was plainly not fit for purpose. He highlighted that 20% of the GP estate predates the founding of the NHS in 1948, and 53% of it is over 30 years old. As I said, GP premises is something we've written about a lot over the years, and we know that many practices are operating in out-of-date buildings with not enough space for all of their staff. The BMA and the Royal College of GPs have been calling for investment into premises for years. An RCGP poll in October last year found that 1 in 3 GPs say their practice premises are inadequate for providing patient care. And the college has previously called for a £2 billion investment to improve practice premises, and also warned that general practice infrastructure, including buildings and IT, are basically falling apart. So that was the term they used. The BMA's also been arguing for significant investment in GP premises for years to ensure practices are able to meet the needs of patients in the 21st century. And I think a proper plan for some of the aspects around premises will need to be part of the ongoing contract negotiations that the government and the BMA will be having for this new GP contract. It's really hard to see how the government can deliver on plans to deliver a neighbourhood NHS and shift more care out of hospitals and into the community unless it actually invests in the primary care estate. And that's not just GP practices, as you touched on. It's also buildings for community services, including nursing teams, mental health, social services. All of that's going to need proper space. And I think there's obviously a real argument to be made. And many GPs, would make this argument that co-location of lots of those services alongside general practice could potentially be really beneficial for how services work together to help improve patient care. Nick, you mentioned that £102 million fund for upgrades and improvements to 200 GP practice premises. That's obviously a drop in the ocean. Do we actually know what's happened with that money yet?
So the Confederation says some of this money has started to flow into primary community services, but that far more is needed to cover the cost of repairing and repurposing existing buildings, as well as building new premises and investing in modern technology and equipment. I mean, as you mentioned, £102 million to improve or invest in 200 GP practice premises is absolutely a drop in the ocean. There are 6,250 GP practices in the country and many more sites than that. Obviously, given the fact that, like you said, a fifth of GP premises predate the NHS, more than half of them are over 30 years old. There's a lot more than £102 million that's needed to start to make a dent in the upgrades that are needed to those premises. And in fact, this is also something that rolls on from what we've talked about when it came to the ARRS. The ARRS was something that intended to put, around 30,000 additional staff into primary care. And a lot of the conversation then was that practices simply don't have the room to put these people into. Those people now have been crammed into any available space. Those practice premises are absolutely at capacity and need support if they're going to expand further.
But we know the government is very strapped for cash. We've just been talking about that, haven't we, with the pay review. And there's also obviously a lot of competing demands on the public money that is available. What options are there on the table for actually getting this investment? I mean, has the NHS Confederation had any thoughts on how to raise the capital? Are we going to be looking at more private investment to deliver on premises?
So the NHS Confederation published a report recently that set out some of the options it wants to see come into play. Ultimately, it said the government has to explore increased borrowing to fund investment in infrastructure. It should look at how to get more out of the existing NHS estate and also look at shared investment models to improve premises. That basically means considering the use of public-private partnership models to boost investment in healthcare premises, and exploring how third-party development could expand and improve the NHS estate. I mean, that's something we saw with the likes of Lift under Labour governments in the 2000s. But, ultimately, if they don't get their act together and invest in primary care premises, the scale of the lack of capacity for primary care to take on the kind of work that's needed to shift more stuff out of hospitals and into the community is made clear by some of the polling that the Confederation has done with NHS providers recently. They found that 9 in 10 community provider leaders said they didn't have enough capital funding, and basically a similar proportion say their buildings and facilities as they are a barrier to improving productivity.
So the spending review, which is part of the reason why the NHS Confederation is calling for this, that spending review, which is basically going to set out the government plans for spending and key public sector reforms for the 4 years taking us through to 2028-29. That's due to conclude on the 11th of June. And that's going to set out plans for day-to-day spending for the next 4 years and capital funding, so separate investment into infrastructure like premises and buildings for the next 5 years. There's also going to be a separate 10-year infrastructure strategy, which is due to be published at the same time. The government has said this is not going to be a business as usual spending review, and apparently they're going to be using this as an opportunity to rewire the state to deliver on Labour's plan for change. But obviously, it's quite a movable feast, and pressures on the economy and the public purse seem to be changing on a daily basis. Obviously, we're also awaiting the 10-year health plan. So this is the 10-year strategy for how the NHS is going to change. And I'm sure that is probably being developed very much in tandem with the spending review. So what we're likely to see in that plan will obviously need to reflect the funding the NHS has given as part of the spending review. So June is going to be a pretty key month for getting a sense of where we're heading in terms of the NHS's strategy and whether the government is going to invest enough money to enable the health service to actually deliver on that vision. Before we go, we've just got time for our good news story, which this week is an update about something we talked about on the podcast a few weeks ago. This is actually one of our senior reporter Kimberly Hackett's story, but I'm going to talk through this because she's out covering a conference for us today. So a couple of weeks ago, Kimberly told us about almost 200 practices represented by the Lancashire and Cumbria consortium of LMCs that were considering boycotting a basket of local enhanced services in their area because the ICB had slashed its initial funding proposal by almost £17 million due to financial pressures it was facing. Well, the good news is that following discussions and that threat to boycott the local enhanced services in their entirety, the LMCs have secured an increase in the funding, which will see the total paid to practices increase by 14 million compared to what they were paid last year. LMC Chief Executive Dr. Adam Janjua said without the collective effort of practices, the funding uplift would not have been possible. Well, that's it for this week. Thanks so much to Nick and thank you for listening. I'll be back next week when I'm speaking to former RCGP chair, Professor Dame Helen Stokes-Lampard, who left the UK 6 months ago to take up the post of National Chief Medical Officer in New Zealand. I'm talking to her about how that move has gone, the differences between general practice in the UK and New Zealand, and also she provides some advice for aspiring GP leaders, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.